thank you to Dr. Pandit, to the Reliance Hospital, as well as the Society of Neurocritical Care for giving me this opportunity to speak here. So my talk is going to be about cerebral autoregulation-based therapy at the bedside and how it can be used to personalize care in neurocritical care. I have some minor disclosures. The objectives of the talk is first to identify why there's a need for a personalized approach for blood pressure management in acute brain injury and in the neurocritical care patients. And then just a brief overview of the cerebral blood flow physiology and how we can use that understanding to measure cerebral autoregulation at the bedside and then personalize therapy using that. And then what available data is there currently for cerebral autoregulation in acute brain injury patients. So as we all know, altered cerebral perfusion, either ischemia or hyperemia, both are the final common pathway for secondary brain injury, which prevention of which is the main goal of neurocritical care. And therefore, blood pressure management is the cornerstone for what we do in the neuro ICU. But despite that, there's really not good evidence for any specific blood pressure thresholds. And I'll just highlight that in the subsequent slides. So for example, in intracerebral hemorrhage, we had two big trials, the INTERACT-2 trial in 2013 that compared a blood pressure goal of less than 140 to less than 180. And although there was a trend towards improved outcomes with the lower goal, this did not achieve statistical significance. And then a follow-up trial, which was the ATAC-2 trial, compared 110 to 140 versus 140 to 180. And there was really no difference in outcomes with either of the two blood pressure goals. And in multiple subgroup analysis, they actually showed that when people were very high and you brought them down to below 140, there could actually be a signal for harm. For example, in the figure on the right, they used group-based trajectory modeling to identify, using machine learning methods, identify different trajectories of blood pressure after ICH. And this is in the ATAC-2 patients. And the green line, which is the ones that went from really high to very low very quickly, that group actually had higher odds of death, disability, as well as other adverse events. But why do we lower blood pressure in ICH? The goal is to reduce hematoma expansion, and there's also some evidence that it can reduce perihematomal edema expansion. But also from an analysis that we did from the MISTI-3 and CLEAR-3 patients, cerebral hypoperfusion, so if anybody that had a cerebral perfusion pressure less than 60 at any time point in the first month while they were in the hospital. And those patients with ICH that developed acute ischemic strokes in the acute period, which is in the first month, those patients had worse long-term outcomes. And so while lowering can help, it can also be harmful to some group of patients. Similarly, with acute ischemic stroke, we all know about the U-shaped relationship between blood pressure and outcomes in acute ischemic stroke patients. So really low blood pressures, usually below, which can be variable depending on the studies you look at, but between 110 to 130 on the lower limit and more than 220 on the upper limit, both have been associated with worse outcomes in patients with acute ischemic stroke. And we don't really have a specific blood pressure threshold that is actually associated with improved outcomes in patients that did not receive reperfusion therapies, as well as in patients that received reperfusion therapies. And while we actually do lower the blood pressure after mechanical thrombectomy, there were two recent trials, the BEST-2 trial that looked at blood pressure reduction below 140 to 160 versus 180, and there was no difference in outcomes. And in the ENCHANTED-2 trial, where they did more aggressive blood pressure reduction, so less than 120 versus 140 to 180, actually showed harm with lowering it below 120. So again, there's a lot of controversy about what is the most ideal blood pressure threshold. There's one more trial that I haven't included here that compared less than 140 to 180 and actually showed no difference in outcomes. So we don't really know what is the most ideal blood pressure after mechanical thrombectomy. With subarachnoid hemorrhage, this is even more complicated. So in the acute phase, we do aggressively lower blood pressure because we want to prevent the aneurysm from re-rupturing. But during that phase, the patients also have hydrocephalus, elevated ICP, and may have global edema. And so lowering the blood pressure can actually be harmful by causing ischemia. And there is actually no trial that has shown that lowering blood pressure is safe or effective. And there is a lot of controversy in observational studies about what is the most ideal blood pressure that you should lower to in the acute period before the aneurysm is secured. After the aneurysm is secured, again, there is no data about what is the most ideal blood pressure. We know that in this period now, between the first 24 to 96 hours, a subgroup of patients have ongoing early brain injury. That is, they have microcirculatory dysfunction that is already decided during this very early period. And during that period, while we just allow the patient to be, standard blood pressure, MAP greater than 65, for example, we don't know that in those patients where there is microcirculatory dysfunction, whether that is what is predisposing them to develop delayed cerebral ischemia. And then delayed cerebral ischemia, which was used to be called vasospasm before, once that does happen, the standard practice is to raise the blood pressure with the vasopressors. But again, we don't really have good evidence that that is effective. And if we do, how much should we raise it, how long we should raise it, and whether there is harm associated with it. The only randomized control trial that looked at induced hypertension with DCI, which was the Himalaya trial, they did stepwise augmentation of mean arterial pressure after the patients developed symptoms of vasospasm or DCI. And the trial was prematurely terminated due to slow enrollment, but there was really no signal of improvement in function outcome. And higher risk serious adverse events in the induced hypertension group. There are several observational studies that actually showed a higher risk of cerebral edema as well as mortality with use of vasopressors and subarachnoid hemorrhage as well. And so there is a lot of controversy about what we should do with blood pressure. And although we set all these goals every day, we don't really know what is the most correct goal for these patients. And so I think the answer to all of this is likely that we need to use a more individualized approach to defining blood pressure, probably guided by the cerebrovascular physiology. And these blood pressure thresholds are going to be dynamic, so they're going to change as the disease process changes after the acute brain insult. So before going into how we can do that, I just wanted to give a quick overview of cerebral blood flow, just so that it's easier to follow how we measure it at the bedside. So we all are aware that the brain does receive a large amount of the cardiac output, and a normal cerebral blood flow is about 50 ml per 100 grams of brain tissue per minute. And as the blood flow decreases, the ischemia starts ensuing, and usually once it drops below 20 ml per 100 grams per minute is when we start developing ischemia, and then less than 10 leads to infarction. Cerebral blood flow and cerebral perfusion pressure are different. Cerebral perfusion pressure is the pressure that is generated in the microvasculature by the blood flow. And so it is the difference between the intracranial arterial and venous pressures. Arterial pressure is the mean arterial pressure. Venous pressure is mainly defined by the ICP. And so the CPP is basically MAP minus ICP. On the other hand, cerebral blood flow is the flow which is change in pressure by the vascular resistance. And the vascular resistance, this is the formula for resistance. And assuming that viscosity and length remain constant, the main driver is the radius of the vessels. And so cerebral blood flow depends on both the cerebral perfusion pressure as well as the diameter of the arteriolar vessels. And that's mainly the main driver in minute by minute for cerebral blood flow. To maintain cerebral blood flow is actually how the vessels change. And so that is regulated by various different mechanisms. So the neurogenic mechanism is also known as neural astrocyte coupling. So this figure on the right shows how astrocytic foot processes surround the vessels, and every time there's increased metabolic activity, they release mediators that cause vasodilation. So that's called neurogenic mechanism of cerebral blood flow. We have metabolic that we are commonly aware of, which is PCO2 as well as PO2. Endothelial, which is by release of mediators by the endothelium of the vessel. And then the myogenic mechanism, which is also known as cerebrovascular pressure reactivity. And that is the main mechanism that drives cerebral autoregulation, which is how the vessel smooth muscles respond to changes in pressure, transmural pressure. So CO2, this was first demonstrated by Ketty and Schmidt in 1948. So healthy subjects were made to inhale 5 and 7% of CO2, and the cerebral blood flow increased by 50% and 100%. And using the calculations, they showed that for every millimeter of mercury change in CO2, the cerebral blood flow changes by around 2 to 4%. The relationship with oxygen is much less linear. So when it only causes a change in cerebral blood flow in severe hypoxemia. So when the PO2 drops below 50, there's a steep sudden rise in cerebral blood flow. But beyond that, there isn't much of an impact of oxygen on cerebral blood flow. The myogenic mechanism is what it drives the cerebral autoregulation. So it is also known as cerebrovascular pressure reactivity. So for every 10 to 25 millimeter of change in the transmural pressure, the vessels will either dilate or constrict. So if the pressure increases, they constrict. If the pressure decreases, they dilate to maintain a constant cerebral blood flow. And so that is what this figure, which is what is classically taught for cerebral autoregulation, which was first shown by Lassen, where you can see that over a wide range of blood pressures, the cerebral blood flow is maintained constant by this dilation constriction of the vessels. When you reach these limits of the autoregulation, then the relationship becomes linear. That is, every time at the lower limit, as the blood pressure drops, the cerebral blood flow decreases and causes ischemia. And on the upper end, it causes increased blood flow and hemorrhage or vasogenic edema. This was first shown by Niels Lassen in 1959, where he measured cerebral blood flow at different blood pressures in healthy subjects, and he showed that over a wide range of pressures, the blood flow remains constant. But this mechanism is likely altered after acute brain injury, and that's the whole point of individualizing pressure, because that plateau phase is probably different for different patients. And there's also a relationship with ICP. So when the cerebral perfusion pressure decreases, you get cerebral vasodilation, and that causes an increase in cerebral blood volume and an increase in ICP. And on the other end, vice versa. So there's an inverse relationship as long as autoregulation is intact between CPP and ICP, or the blood pressure and ICP. So to summarize, arterial blood pressure and ICP regulate the CPP, cerebrovascular reactivity and cerebrovascular resistance basically drive the cerebral blood flow, and cerebral blood flow controls ICP. And so there's sort of a feedback mechanism going on. So how do we use this to measure cerebral autoregulation at the bedside? So there are two types of autoregulation. There's something called static autoregulation, which is the classic autoregulation curve shown here. This is measuring the degree of the changes in the vascular bed in response to maintain the cerebral blood flow. But it cannot be done at the bedside. It's invasive, and you have to actually pharmacologically manipulate the blood pressure, and then it just gives you a snapshot measure. The other way of measuring cerebral autoregulation, which can be done at the bedside, is the dynamic autoregulation, which is measuring the rate of the changes in the vascular bed. So over time, you see how the blood pressure changes and what happens to the cerebral blood flow in real time. And then looking at the difference between the rate of change is how you can measure autoregulation. I'll talk about it in the next slide. So for this, it uses the idea that low frequency changes in the driving pressure, which is MAP or CPP, are actively counteracted by vasomotor reactivity. So all you need is a continuous surrogate measure of cerebral blood flow at the bedside. There's no way to actually measure cerebral blood flow at the bedside, but we use different surrogate measures. For example, in this figure, it's transcranial Dopplers, but you can use other technologies that I will talk about. And then you also need continuous blood pressure monitoring with an arterial line, and then using a software and time domain analysis, you can correlate the surrogate measure and the blood, either the arterial blood pressure or the CPP, to calculate a correlation coefficient. And that correlation coefficient is the autoregulation index, which ranges from -1 to 1. So if you look at this figure in the top panel, the arterial blood pressure is decreasing, but the cerebral blood flow velocity remains constant. So there is no correlation between the two. The R is 0.1. And so this indicates intact cerebral autoregulation, whereas here, as the blood pressure drops, the cerebral blood flow velocity also goes down, and there is a linear correlation indicating impaired autoregulation. And so the closer the autoregulation index is to 1, the more likely the autoregulation is impaired. And usually the threshold is defined as about 0.3 using healthy subjects. So there are different measures you can use, both invasive as well as non-invasive. They all have their own limitations. The invasive measures include ICP, which is the surrogate is it's a surrogate of cerebral blood volume, assuming that the CSF remains constant. And then you can also use brain tissue oxygen tension monitoring, or PPTO2. And then non-invasive monitors like transcranial Dopplers and near-infrared spectroscopy. And so these are the different indices that you can generate using ICP. There's the pressure reactivity index or the pressure amplitude index, and then using PBTO2, which or the Lycox monitor, the oxygen reactivity index. And then non-invasive methods include TCD, so mean flow velocity index, and then NEARS, which measures the cerebral oxygen saturation. So you get the cerebral oximetry index. And so in a healthy person, when the CPP goes up, cerebrovascular reactivity kicks in, the cerebral blood volume goes down, ICP goes down. So there would be an inverse relationship. When the autoregulation is impaired, this cerebrovascular reactivity is not kicking in anymore. And an elevation in CPP causes an elevation in ICP. So there's a linear relationship. And so this is a snapshot from that software that we use called ICM Plus software. And you can see in the top panel, as the blood pressure is going up, the ICP trends down and there's an inverse relationship. Whereas here, as the blood pressure trends down, the ICP trends down, there's a positive relationship. So this indicates impaired autoregulation, and the R is around 0.65. The other measure is the oxygen reactivity index. So you place the Lycox monitor in the brain parenchyma and you measure PPTO2, and then you correlate that with CPP. And so in this panel, you can see as the CPP drops, the PPTO2 also drops, indicating impaired autoregulation. Whereas here, there's a drop in the CPP, but the PPTO2 remains constant, so indicating intact autoregulation. And then the other tool that we use at Hopkins is near-infrared spectroscopy. So it is a non-invasive measure of cerebral blood flow, but it basically emits near-infrared light, and then there's a detector that calculates the ratio of the venous and arterial blood. It can measure deoxygenated and oxygenated hemoglobin, and then using a proprietary algorithm, generates the cerebral oxygen saturation as well as the total hemoglobin volume. And then correlating that with the map, you can generate different autoregulation indices. So there are two types of devices, the INVOS as well as NERO, and all of them have their own algorithms, and each of them have their own, but all of these basically mean the same thing. They have a threshold around 0.3 as abnormal. And this is, again, showing the same thing with NEARS. So the advantage here is you get a different value for each hemisphere, so right and left as well. So they all have their own limitations. So the ICP one is, although it is the global measure of autoregulation, it doesn't give you a lot of information about local cerebral autoregulation or what's happening in the microcirculation. And then at very low ICPs, the effect is dampened because you may not see a lot of changes in changes in ICP. The changes in blood flow in the ICP is very low, and the compliance is intact. The Lycox monitor, again, it's an invasive measure. The problem is that it's very regional, and there is a lot of debate about where to put it, whether you put it in the lesion, around the lesion, or on the normal side, and you're going to have different values. And it only measures the brain partial pressure of oxygen about a 1 centimeter diameter around the probe, so you don't really know what's happening on the other side. TCDs are labor intensive, and they assume that the proximal vessel is not really changing. If the patient is having vasospasm, for example, then it may not be as reliable. And then NEARS can be contaminated by the extracranial circulation. And again, it only measures the frontal lobe, so we don't know what's happening elsewhere. So there is, again, a lot of debate about what is the best method. So how do you use this to personalize therapy? So again, we discussed about the autoregulation curve. And so the idea is to find this plateau phase where the blood flow is constant. And so this can be done, again, the software does that, but it plots the patient's blood pressure on the x-axis, and then the mean autoregulation index corresponding to each blood pressure on the y-axis. And then using that, you can fit a parabolic curve, and wherever the curve is closest to zero or below zero, that is the optimal blood pressure for the patient. And then wherever it crosses the threshold of abnormality, which is usually defined as 0.3, those are the limits of the upper and lower limits of cerebral autoregulation. So you're trying to, this is the area where you want to maintain the blood pressure, and as much as possible, around, for this patient, it would be around 85 to 95 range. And so you can see this is where the patient's actually spending their majority of their time, which is below 75. And so you can do the same thing with CPP if you have invasive ICP and CPP monitoring. And then you can also use that to individualize ICP thresholds. It can also guide, I think there are some questions, but it can also guide whether there is an effect from therapies. For example, vasopressors will only be effective if the autoregulation is impaired, because if the autoregulation is intact, it will be counteracted by vasoconstriction. And so this was actually shown in this small study where they did TCD monitoring and measured the autoregulation and divided the hemispheres as those that had intact autoregulation versus those that had impaired autoregulation. And then they measured the cerebral blood flow velocities before and after starting vasopressors. And you can see that the cerebral blood flow velocity only increased on the hemispheres where the autoregulation was impaired, but where these are all the hemispheres where autoregulation was intact, and there was not much change in the blood flow velocity despite adding vasopressors. And also mannitol. So one of the mechanisms by which mannitol lowers ICP, it works immediately. So it's not really the osmotic diuresis that immediately drops the ICP, but it is this first pass effect, which is because of its effect on the viscosity of the red blood cells. And so by lowering the viscosity, it causes a transient increase in cerebral blood flow, which is compensated by vasoconstriction and reduction in blood volume and ICP. And so this requires the autoregulation to be actually intact. And so this, again, another small study where they showed that the ICP drop was much more significant in patients that had intact autoregulation, but not so much in impaired autoregulation, because it was counteracted by an increase in cerebral blood flow. So you can use this information potentially in the future to also guide which therapies you would choose. And so what do we know about cerebral autoregulation impairment in acute brain injury? So in patients with TBI, this has been mostly studied in TBI. The large majority of the studies are in the TBI patient population. About 50 to 90% of patients with severe TBI have impaired autoregulation, and impaired autoregulation in the first 24 to 96 hours is associated with higher mortality in patients with traumatic brain injury. This study using the center TBI patient population, they actually calculated that lower limit of cerebrovascular reactivity for all the patients. And although the guidelines currently recommend maintaining CPP above 60, almost 50% of the patients had a higher CPP than 60, which was the lower limit of reactivity for them. And spending more time below that lower limit was associated with higher mortality in these patients. The only randomized control trial that has used this approach is the COG-8 trial, and it's only been done in TBI patients. And it was just a feasibility trial. They wanted to see if it is feasible to actually maintain these blood pressure targets in real time. And so again, it was a small study. They randomized 32 patients to the intervention arm. The intervention arm had Q4 hourly calculations of the optimal CPP. And then the control arm, which just got standard treatment, which is maintaining CPP above 60 and ICP below 22. And they defined their feasibility threshold as if 36% of the time they were able to maintain the CPP in the optimal range for that patient. That was considered that it would be feasible, and they achieved that. So it was about 45% of the time where the CPP was concordant with the optimal CPP. And in the arm that got the intervention, they were much less likely to have low CPP, less than 60, so it was only 6% versus 12%. And there was a lower mortality and a higher proportion of patients with favorable outcome, but the study was small, so it did not reach statistical significance. So still, I mean, although it was feasible according to the study's metrics, you can see that almost 50% of the time they couldn't really achieve that threshold. So it is still a challenge how to implement this in clinical practice. There's also autoregulation data for ischemic strokes. So in LVOs, autoregulation is impaired only in the hemisphere that has the large vessel occlusion, whereas in small vessel strokes, it's bilateral hemispheres. So it's probably because of the long-standing hypertension in these patients. And then if patients have carotid stenosis, then there's impaired autoregulation on that side, and it gets better after stenting. This study was from the group in Yale, where they enrolled 90 patients after mechanical thrombectomy and compared the relationship between spending time outside the limits of autoregulation and discharge as well as 90-day outcomes. And so they calculated the upper and lower limit of cerebral autoregulation. Spending more time above the upper limit of autoregulation is associated with higher worsening discharge MRS as well as 90-day MRS, as well as higher incidence of hemorrhagic transformation. And spending more time below the lower limit was associated with infarct progression. And they also, this again, about a study of 45 patients, but they also showed that impaired autoregulation was predictive of developing malignant cerebral edema after a large MCA infarct. So in this group, where they had no, so this is with invasive monitoring. So the PbTO2 was constant despite changes in CPP. This was the group that had intact autoregulation in the first 6 hours. They did not develop malignant edema, whereas those that had impaired autoregulation were more likely to develop malignant edema after 24 to 48 hours. With ICH, again, very small studies, very limited data. Mostly it remains intact in small hemorrhages, but the relationship is directly proportional to the hematoma volume. And it usually declines after day 3. And that is related to IVH as well as perihematomal edema, and then does predict worse outcomes. And in this study, they showed that the worse the autoregulation, the worse the discharge NIH stroke scale in patients with ICH. And then spending more time below the lower limit of autoregulation was associated with higher odds of developing ischemic lesions on MRI in patients with ICH. With SAH, I think there's a good role of cerebral autoregulation. I think it is probably the most important factor that drives development of delayed cerebral ischemia. So about 42, if you had impaired autoregulation between 48 to 96 hours after SAH, there's a high risk of DCI. And the idea is that it is something called the Harper's dual control hypothesis. So although many patients get vasospasm, if you do an angiogram on all subarachnoid hemorrhage, almost 70% will develop vasospasm. But only a small subgroup actually develops symptoms from the vasospasm. And so the idea is that if the autoregulation is intact, then even though there's proximal vasospasm, the vessels will dilate and draw blood. If that autoregulation mechanism is impaired because of the subarachnoid hemorrhage, then those patients will develop signs and symptoms of ischemia from the vasospasm. And so there are, again, several observational studies using invasive monitoring. So in this study from the Columbia group, they looked at 131 patients with both PbTO2 and ICP monitoring, calculated CPP opt every hour. And then if the CPP was below CPP opt, and you can see we normally, again, would do a CPP target of 60, but the mean CPP optimal CPP was 82 millimeters mercury, so it's 20 millimeters higher than what we would normally do. And if you spend time below that, that was associated with hypoxia using the brain tissue oxygen monitor. And again, the same group in a smaller subset of patients looked at how this changed in patients with DCI. So about 3 hours before the patients developed DCI symptoms, the cerebral autoregulation worsened, and the difference between the CPP and CPP opt increased by about 8 millimeters of mercury. They showed that by inducing hypertension, you are able to bring the CPP above the optimal CPP target. And so we also are doing a study in subarachnoid hemorrhage. So we prospectively enrolled about 40 patients using non-invasive monitoring, so NIRS, and we assessed one-year outcomes. About 40% of the patients developed DCI. This is an example of how the optimal blood pressure changes dynamically. So if this was we calculated daily optimal map for these patients, and you can see on day one, it was around 70. And then by the time they progressed into the vasospasm window, it was around 120. That was the optimal mean arterial pressure. So it changes dynamically over time and shifts to the right. Those patients that developed DCI had a much bigger difference in their observed map and the optimal map than those that did not develop DCI. And there was also TCDs. So the TCDs went across the threshold of vasospasm on day 5, but the optimal map actually started rising as early as day 3. So there was in patients that developed delayed cerebral ischemia, which happened around a median of day 6. And there was a linear relationship between the TCD velocities and the optimal map in patients that develop DCI. So showing that the even before the patient would have been treated normally once the vasospasm started, there was already a difference in their optimal map and their observed map. And we showed that there was an association with worse outcomes at 1 year after adjusting for all of these different factors with spending more time below the optimal map range for these patients. There is some increasing interest in spreading depolarizations in subarachnoid hemorrhage. So the thought is that the spreading depolarizations is probably the key that causes delayed cerebral ischemia in these patients. And so there are some studies that have shown that just before the patient gets DCI symptoms, they're using electrocorticography, spreading depolarizations develop on the cortex of these patients. And so there was one study that showed that these spreading depolarizations were associated with impaired autoregulation. So every time the spreading depolarization came, there was an impairment in the cerebral autoregulation. And so that this might be how the DCI symptoms actually develop in these patients. So the spreading depolarization impairs autoregulation and cause symptoms of DCI. So what about therapies that improve cerebral autoregulation? There were 2 trials. There was one looking at pravastatin in SAH. And although the phase 3 trial actually didn't show an improvement in outcomes, in the phase 2 trial, they used autoregulation monitoring and showed that patients that received pravastatin had a lower, spent lesser time with impaired autoregulation. There was also a trial with erythropoietin, which showed that patients receiving erythropoietin, again, had lesser duration of time that their autoregulation was impaired. Xylostazole may also have which is now becoming increasingly recognized as a potential therapy in SAH. But xylostazole was associated with reduced cortical spreading depolarizations in patients with subarachnoid hemorrhage, and so it may be improving autoregulation, although that hasn't been studied yet. And what about other conditions beyond critical care diseases? So in sepsis, there have been several studies to use this methodology to identify personalized blood pressure thresholds. So to reduce sepsis-associated encephalopathy. So the mean cerebral blood flow velocity, for example, is lower in patients with sepsis that develop encephalopathy. They also have higher impairment in autoregulation and reduced vasomotor reactivity. So finally, are we able to use this? What are the limitations of all of this technology? So although we have enough understanding that a personalized approach is necessary, we don't, because there is no objective data that one specific blood pressure improves outcomes. There are several limitations. So it is difficult to generalize this. It is an expensive technology. You need the monitoring devices. You also, it requires complex interpretation. So how would we use this data for the nurses to make decisions about titrating vasopressors at the bedside? As we saw in the cognitive trial, only about 50% of the times they were actually able to maintain the CPP in the range that was prescribed. There's also a lot of variability in how people use this approach, even among experts that do this research, and especially how they define the optimal CPP, how frequently they should define it. And then there isn't really any randomized control trial that has shown improved outcomes. And so there's still a lot that needs to be done. They actually had a State of the Union. So it was a virtual consensus meeting last year. I also attended it. So there were experts in autoregulation research that have been doing it for a long time that met together and identified what are the next steps to move towards a clinical trial. And they actually found a lot of differences in how they all worked, used this technology. So only 20% actually had a clinical protocol. Everybody else was using it mainly for research. They had a lot of variability in how frequently they were going to measure these targets, whether it's every 4 hours, every 8 hours, every 12 hours. And then they all agreed that before we can use it for clinical use, we should first have more studies looking at feasibility of a treatment protocol that uses this methodology, and then also identify which is the best technology to measure autoregulation, and then eventually do a randomized control trial before we can actually implement it in practice. And so just to summarize, cerebral autoregulation is probably the most important protective mechanism for secondary brain injury. And we do have technologies that we can use to measure at the bedside. And in the future, I think this could be used to personalize blood pressure management as well as identify therapeutic agents that can improve autoregulation after acute brain injury. But we do need a lot more studies before we can start using this. So that's it.
Thank you. Okay, so I think there's some questions in the chat box. Please use AI companion for summary on the bottom panel. Request all to keep mute. Okay. Yash, you have Dr. Yash, you have any questions?
Yeah. First of all, I'd like to congratulate Dr. Vishang Shah for a very, very fascinating talk on the physiology, and it was like a romance with brain physiology, if I can say like that. So thank you for giving us new insights into the physiology of brain. One question I had, you already mentioned about it. What will be the role of statins? There have been some papers about role of statins as an antihypertensive for acute ischemic stroke. Where do you see the role of statins now, sir?
I think all the phase, especially in subarachnoid hemorrhage, phase 3 trials have actually not shown it to be effective. But I know that there is data that it improves autoregulation as well as reduces inflammation. So it maybe in other disease conditions, for example, I know that in cerebral hemorrhage, there's a trial that's ongoing right now, the Saturn trial that is looking at statins. But I think at this point, I don't think we have enough data to use it in hemorrhage acutely. In ischemic stroke, we use it mainly for secondary stroke prevention. Again, I don't know if there is a strong role in the acute setting or there's enough evidence that supports using high intensity statin in the acute setting currently.
Thank you. But are we using as an adjuvant for ischemic stroke and subarachnoid hemorrhage, most of us? Probably Dr. Shah, Arun Shah can also pitch in for this question. What is our practice, sir?
Ischemic stroke, of course, we use it. There's no question. In the subarachnoid hemorrhage also, I have been using it.
You have? Okay. We don't really use it there, but I think there was the STASH trial, the phase 3 trial that did not show improvement in outcomes with statin at that stage. So we don't use it there.
Shant.
Thank you.
In SAH. Oh.
Okay, any question from Dr. Prashant, Dr. Sapra, Dr. Arun Shah? By the way, I have not told the relationship. Vishank is son of Dr. Arun Shah. So I'm going to ask father to ask a question to the son if he had any.
No, I just wanted to know, because you mentioned about PCO2. driving the arterial diameter. And I think when Dr. Pandit had organized a good conference where gentleman from Australia mentioned that PCO2 is using it, PCO2 to improve the cerebral perfusion.
Yes.
So, like, is that a possibility? Is there a study going on like that?
I mean, that was the first time that I heard about it. I haven't seen anyone use that. We do.
Is a part of DCI treatment.
Yes.
Yeah, yeah.
That's what he
yeah.
said, that if you maintain a particular, increase the PCO2, it will help in reducing DCI. That was his
Yeah.
theory, and that's what they are studying. The phase 1 study they have already done.
Yes, but no data apart from the phase 1 study which is
Yeah,
actually there.
I think theoretically, I think it can be done because that mechanism is different from the pressure reactivity that drives the autoregulation. So PCO2 affects the blood vessels, from my understanding, from what I've read about autoregulation literature. It affects the blood vessels regardless of the changes that happen with the changes in the transmural pressure. So even at different phases or parts of the autoregulation curve where the patient might be, CO2 can still continue to have its effect on the patient. So I think it can definitely be used. It would be hard to induce hypercapnia in clinical practice. I guess you have to infuse CO2 maybe, and how you would do that.
At the moment, I think they were just using hypercapnia to sort of just slow down the
If you're
respiration
ventilated,
and
right?
ventilated. Yes.
Yeah,
So
yeah.
it was
If
only
you're
for
not-
ventilated patients.
Yeah, if you're not ventilated, I don't know. how
Only
it
for
works.
ventilated patients.
Although in ECMO, there are ways to infuse CO2.
Yeah, but ECMO would be like too far fetched.
No, but like you could
Yes,
theoretically infuse it
theoretically
in
you
another method. Yeah.
So, Dr. Sapra, any questions, or if I have a question, then anything from your side?
I just wanted to ask a question. Thank you for a wonderful talk. I think you have covered all the aspects of neurocritical care, all the major subsets. My question is that pressure reactivity and PbO2s are not available in India. The technology for PbO2 is not available. Pressure reactivity, we try to get it with the help of the Cambridge group, but it has its own limitations as to not for the technology, but for us to get it into our intensive care units. So, what has been your experience with the cerebral oximeters? Has it been encouraging or
Yeah. So yeah, there's a lot of controversy about the NIRS device. There are some people that do not believe in it as much. I think my understanding is that for autoregulation, it is pretty reliable and accurate. So although the actual number that you get is not as sensitive to changes, so you can't really use the NIRS oxygen saturation to make clinical decisions by itself. But when you correlate that with the blood pressure and look at trends, the autoregulation indices that are generated from NIRS actually have very good correlation with pressure reactivity. So they have been correlated in several studies with invasive ICP monitoring, and the correlation coefficient is the correlation between the two is very similar. It's actually better than with PbTO2. So for autoregulation purposes, and even in that the State of the Union meeting where the Cambridge group, Peter Smielewski was also there, they all agreed that NIRS is a good a way of measuring autoregulation if invasive ICP monitoring is not available. We have the same issue with ICP. We place EVDs, but the EVDs are, at our institution, we keep it open and only clamp it every hour to measure the ICP number. And so when the EVD is open, the pressure is not accurate. So we can't really get an accurate, continuous measurement of pressure reactivity. In centers that do use it, for example, the Cambridge group and Columbia, they place a separate probe that measures the ICP continuously in addition.
yes?
Our neurosurgeons would never agree to place a second probe. So,
So the Cambridge group is totally into pressure reactivity, but the problem is the software, and you need to get every patient analyzed with their software. So what we do is we use the NIRS, we use the flow track for our systemic arterial SVRs and cardiac outputs and augment the blood pressure accordingly. But what we have found with NIRS is that it's a good guide for autoregulation. We use it quite frequently in SH patients, but the problem comes because of the regional nature of the NIRS. Some majority of the times, vasospasm and DCI areas don't correlate. So there comes the problem with the NIRS because you just apply it onto the frontals and then, you are not sure. You can't take a decision based on NIRS.
Yeah.
I'm sure with the advent of time, they would probably be able to target other subgroups of the brain where it. I've raised this question to quite a few NIRS companies as well as regards putting the probes up anywhere else apart from the frontal lobes, but I don't get an answer from them either as yet.
Yeah, I mean, it's only been validated for the frontal. I mean,
Yeah, exactly. Mhm.
this bone, this temporal window is much, the bone is thinner there, but then the hair and everything you would have to, yeah, that would come in this.
Yeah, so we use a combination of TCDs and cerebral oximeter along with augmentation based on the flow track device. So that is ICP. We do get a parenchymal probe in if need be.
You have the Cambridge software as well to calculate.
We haven't. We are still analyzing whether we should or should not because PbO2s is something which we don't have, and pressure reactivity. You have to validate their software every so often, and there's a cost to it. So not yet, but probably in the pipeline.
So I'm happy to know that PbO2 still the debate is which side to put in. That debate has still not improved.
We'll know
When I used
the-
it in 2003, 2004 when it was initially brought
Yeah.
out. And still the question was, do we put it on the bad side or do we put it the good side by putting it on the good side? So
I think at this point, it's mainly, they put it outside the lesion.
yeah.
But the boost 3 trial is going on, so they will know.
What about cerebral microdialysis?
I don't think that, I think that's pretty much, nobody really has been using that. It's only right now in research. Yeah.
Any more questions, gentlemen? Anybody from the delegates who wants to speak? Anybody has a question? Anybody from the delegates who are present here has a question? Yes.
So now the debate of controlling the pressure in ischemic stroke aggressively is outdated. Normotensive, little more also. What are your thoughts of post AVM embolization control of the pressure?
Yeah, again, not been studied very extensively. In our center, they are very aggressive. It's more for AVM resections, but they lower the blood pressure to very low levels, almost like 120 or lower after AVM resections. For AVM embolizations, we use less than 140, but pretty strictly. I think the neurosurgeons, what I've understood from the neurosurgeons is that they're, because of the sudden change now in the once the AVM is gone in the arterial and venous gradient, they are very concerned about hemorrhage. So they want the blood pressure to be lowered very aggressively. I don't think that's really been based in big studies, but that's just what the neurosurgeons kind of drive the blood pressure lowers.
And number two, now we are doing large core thrombectomy now.
Just speak loudly.
Okay. I don't know. So in large core thrombectomy, what is your experience of early decompressive craniotomy versus aggressive decongestant management? You feel that the craniotomy group is having worse outcome than aggressively managed AV managers. So all this earlier thought process of decompressive craniotomy was earlier is better because road traffic accident, all those things were there. The large core thrombectomy has created a separate group altogether.
Yeah.
Different song, very little experience because it's just 3 years. So in 2 to 3 years, what is your experience? Aggressively managed decongestant versus early decompressive craniotomy.
I think even in if the edema is developing, I think early decompressive training. I don't think the hypertonics do much in malignant edema. They can buy you time, but if they're not going to do a deep craniectomy soon, and then it's pretty much for
That's it.
yeah.
And have you noticed that they are having more physical conversion than the regular malignant?
The ones that yeah, because you're reperfusing it, I think definitely there is a high.
No.
Yeah.
Post decompression.
Oh, post decompression. I haven't really seen that. It's very
About that,
No.
in
I know
general. I
this is
think
your viewpoint, but I.
So that's we are discussing, for almost 2 years now.
I think you're seeing worse outcomes because after the thrombectomy, people are waiting longer to do the craniectomy because they think that it will reduce the likelihood of needing a craniectomy, which I think the trials have shown that the people
Yeah.
in large cohort that got thrombectomy had slightly lower need for any
Yeah.
craniectomy. But maybe that's why you're seeing that the people that get a craniectomy are doing worse because people delay the craniectomy.
No, so they all are worse, not because of the delay or the related to the compressive functional loss. They are worse because of hemorrhagic conversion. You
Yeah.
decompress and it gives something we don't understand. We say that the laceration of the cortical or bridging vein or something, but their conversion of post decompression hemorrhagic conversion is much higher.
I mean, it could be theoretically because of the
Tamponade is gone.
tamponade is gone. There was the same debate even with ICH where they would say that doing a decompressive craniectomy in intracerebral hemorrhage, the neurosurgeons would say that they did not like to do that because then the hemorrhage starts expanding because now you've taken the bone off and the tamponade effect on the artery is gone.
So our discussion will continue few more months. Yes.
Some
I
discussion
think-
will continue for 2 decades.
You have to do a heavy
don't think-
craniectomy if
No,
needed, yeah.
Nishant, I don't agree with
No.
you there. I think you have against decompression and 2, 3 patients you have said that, but I am very convinced that
Really?
decompression works. But that last patient is
So
not.
this is not.
But you have to do it early.
Yeah, I get to do it at time the way we
Timely,
were doing it.
timely
Yeah.
decompression.
Yeah, so those are agreed. Those things where you see the classical malignant one, but where the islands of barriers are preserved.
See, this subject, I'm considering is only, this subject has been very well answered by the trial. And trial has said that if you have radiological feature of massive edema and drop in your NIHS 1A, that's it. These 2 criteria if you follow, I think you're doing very well.
Even with the
48 hours,
Yeah, I
within
think so.
48
I
hours.
think so. That's not changed.
All right, thank you very much. Dr. Prashant, आपने कुछ पूछा नहीं? Any questions from your side?
Younger the patient earlier.
He is traveling and probably some signal issues.
No issue.
Yeah.
Thank you very much, gentlemen, for joining. I really thank Vishang for delivering such a lucid talk. As Dr. Yash said, physiology was fascinating in the talk, and so was the way in which you can actually modify the autoregulation. It remains to be seen whether it's going to benefit on a consistent basis or not. Unfortunately, medicine is complex, and we tend to understand very little of the brain. So complexities of microcirculation and autoregulation are even more complex than what we actually understand right now. But thank you for throwing a lot of light into it for all the audiences, for all of us, and coming up to the speed that what we are doing is actually okay at the moment. Though
Yeah.
we don't have the monitors right now, but we are still following the same principles.
Yeah.
We would love to have those monitors. And panelists, thank you very much for your enlightening questions and answers on that. I thank everybody. I thank Arun Shah sir for guiding us always. And thank you for joining this. SNCC, thank you very much for this. And Reliance, thank you very much for always supporting our educational endeavors. Thank you.
Thank